So welcome everyone. Thank you so much for joining this session. Today we are going to talk on AMR, and AMR is such a vast topic that we will try to cover certain aspects of the AMR. By virtue of introduction, I am Anvesha. I work as a Senior Deputy Director in NATHEALTH, and I'm so delighted to welcome you all to this Expert Speak session. This NATHEALTH Expert Speak series is basically to deliberate on how we can provide immediate and concerted efforts aimed at mitigating the rising impact of AMR, which not only poses a grave threat to public health, but also have far-reaching socio-economic consequences. NATHEALTH is running this series of expert sessions on key relevant issues, and today we are going to discuss on AMR. The idea is actually to create a comprehensive platform for stakeholders to discuss this critical issue and to deliberate on the steps to be taken by the healthcare fraternity. The next topic in this expert series is on data security and privacy, and which is being organized on November 17th, and the registration details will be shared with all of you shortly. So today, to discuss on this topic of AMR, we have a very eminent panelist, and you can see them on our screen. A very warm welcome to all of you. The panelist needs no introduction, but still I would like to welcome Professor Sarang Deo. He's Professor ISB. He has recently done a research specifically focused on proposing strategies for improving access to new antimicrobials in India, and he will be giving a short presentation. Post that, we'll have a panel discussion, and the panelist will be Dr. Nitin Bansal, Consultant Infectious Disease ICMR. He's also associated with Rajiv Gandhi Cancer Institute. Our second panelist is Dr. Arvind Taneja, Senior Consultant and Chief Advisor, Max Hospital. He would be joining us very shortly. Our third panelist is Dr. Anita Arora, Director Medical Operations, Group Head Infection Prevention and Control, Fortis Healthcare. And our moderator, Dr. Dev Kishore Gupta, Director and Head Medical Affairs, South Asia Biomedics. So without much ado, I very warmly welcome you all, the panelists, and I will request Dr. Gupta, our moderator, to please facilitate the discussions. Over to you, Dr. Gupta.
Thank you so much, Anvesha, for this opportunity. I think this is a great topic and great eminent panelists who are among us today. And, you know, the need of the hour is very much there with AMR, and this is high time that we must learn from each other and collaborate among each other. So it gives me immense pleasure to introduce Professor Sarang Deo, who is a Professor of Operations Management and Deputy Dean, Faculty and Research Executive Director, Max Institute of Healthcare Management at the prestigious Indian School of Business. So his primary area of research is healthcare delivery system. So this gives a fantastic angle to learn various other aspects of mitigating AMR. Professor Sarang Deo is interested in investigating the impact of operations decisions on population-level health outcomes. He has worked in the influence of vaccine supply chain and the phenomenon of ambulance diversion in the US, HIV early infant diagnosis networks in sub-Saharan Africa, and formal and informal pathways in TB diagnosis in India. So has regularly collaborated with the international public health funding and implementation agencies such as Bill and Melinda Gates Foundation, CHAI, and PATH for his research. So this is really a great opportunity to learn from you, Professor Sarang Deo. So the stage is all yours. So I invite you to share your screen and start your lecture.
Thank you, Dr. Gupta, for that kind introduction. Let me see if I can. Is my screen visible?
Yes.
Okay, so thanks again for the invitation and opportunity to talk about our study. This was concluded a few months ago, and I'm only one member of the team. This is done with my colleagues, Deepak Jaina and Parshuram Hotkar, and our research associates, Mohammad Nigda and Sweetie Shreyashi. And the study was funded by the Center for Global Development Europe. Again, as was mentioned earlier, AMR is a vast topic, and we decided to pick one slice out of it, which is focusing on access to next generation or newer generation antimicrobials. Now, there are usually three legs to this stool. One is access, the other is innovation, and the third is stewardship. So, and I know that there are, different stakeholders who worry more about one leg of the stool than the other. In this study, the focus was on access, and you will see it doesn't mean that we do not pay attention to stewardship or innovation. They will feature in the presentation, but the focus is on access. So at the outset, let me apologize if I'm not able to do justice to those other two legs of the stool. But in the interest of time, here the focus will be on access and access to new generation antimicrobials. Okay, let's see. Okay, so the methodology that we followed was really, there were 4 phases. The first phase was doing some kind of a secondary research on what is the status of AMR in India, what kind of policies and plans exist, in particular around innovation and access. I will not focus my attention on that part today. And then phase 2 was really doing primary research, identifying the key stakeholders, and then understanding from them what the challenges are related to access, based on which in phase 3 we developed some recommendations, which were then again socialized with key stakeholders to understand if you've understood the situation correctly. And then phase 4 was dissemination. An event was organized in Delhi a few months ago, and even this could be thought of as a part of that dissemination. Hold on. Let me just reshare. My apologies for this. Okay, can you see my screen again?
Yes.
Okay. So so there were 2, like I said, the focus was on access, but there was also some work we did on innovation. And this slide captures some of the key challenges associated with innovation when it comes to new generation antimicrobials. And you can see there were 4 categories, 4 themes that we identified. One was around the regulatory system. There was a lot of stakeholders expressed concerns, questions around our clinical trials infrastructure policies, and given the gaps in those, they felt that the companies that are trying to innovate on new antimicrobials may find it difficult to navigate the current regulatory regime and register their clinical trials in the country, and as a result, which could lead to further delays in introduction of these new drugs. There is, of course, not limited to antimicrobials, but more broadly concerns around infringement of intellectual property rights. Again, people could not give specific instances, but there was just an overall sentiment around this. And so it was felt that if data on new drugs was generated within the country, could it lead to some kind of information spillover, which could be detrimental to the business of pharma companies. But I think one of the interesting things that came out really was the fact that the molecular mechanisms for antimicrobial resistance in India could be different from those in other parts of the world. And this means that different types of antimicrobials with different mechanisms may be needed given the AMR landscape in India. And it would be very helpful to have some kind of a target product profile coming out of the country, which could then inform the R&D investments and efforts of different pharmaceutical companies. Consequence of all of these factors is that the market size for, or the demand size for new antimicrobials is uncertain as of today. And as a result, when faced with uncertainty, companies tend to be risk averse. This was identified as one of the potential areas where the government could step in. But at the same time, it was felt that the current efforts, while DBT is taking a lot of effort and putting in funding, that funding may have to be stepped up significantly if we were to see that funding translating into some leads and eventually new products. So that's on the innovation side. On the access side, we spent a lot of time understanding how the procurement happens both within the public as well as the private sector. And a lot of interesting insights came out of the public procurement channels, specifically the medical supplies corporations that have been incorporated in many states. And we found that, of course, all of these work on certain variation of the essential drug list, but most of these drug lists are focused not on high-end antimicrobials, but those which are either in the so not the reserve categories according to WHO, but either access or watch categories, and mostly access. So this came out as an important consideration. There was also a demarcation between those who decide on the essential drug list and then those who procure based on the essential drug list. And there was a lack of communication often between these two entities. And as a result, the Medical Supplies Corporation's standard response was, we procure everything that we are asked to procure. But oftentimes what they are asked to procure is based on historical data. And so we get into this vicious cycle where if new innovative drugs have not been procured because of budgetary constraints or other factors, then they are never procured in the future because the process is very sort of path dependent based on what has happened in the past. Given that there is a lot of increase in financing for healthcare, we also looked at, well, what could it take for schemes like the PMJ scheme to cover these new generation antimicrobials? And there are these benefit packages, and most benefit packages do not call out drugs separately. Also, given the restricted pricing of these benefit packages, they often cannot cover for new generation antimicrobials, which may be more expensive. And there has been some discussion of modifying those benefit packages to allow for high-end drugs, not just antimicrobials, but say cancer drugs. And that could be one potential area where some changes in policies could be brought about. So that's on the access side. So I've identified the challenges both on the innovation and access. And then those led us to frame certain policy recommendations. One was to focus the attention sharply on redesigning essential drug lists, which have, in our assessment, focused primarily on covering a large size of the population under some limited budget. As a result, most of these cover very basic antimicrobials. Maybe an alternate approach is to focus on those antimicrobials that lead to high out-of-pocket expenditure because of unaffordable prices, and leave out the more basic antimicrobials or reduce the coverage of those if the budget is a concern, but at the same time focus on expanding the budget and increase the coverage of the EDLs. The other recommendation is we found that a lot of states were trying to procure these high-end antimicrobials in a case-by-case basis, and that was leading to a lot of transaction costs because not having the history of having procured these drugs, they did not find the reference pricing, which made it difficult to procure under government rules. And then they often sought information from other states, and this process was quite ad hoc. So if I know someone in another state, in another state's supply corporation, I may call them, I may get some information, hopefully some documents that I can use as a basis for my procurement. But potentially, one could envision a scenario where states actually coordinate. At the very least, one could think about a portal where information on different procurement contracts is shared across states, which then acts as a basis. So think about this as information pooling, if not actual physical pooling of procurement, which can lead to more efficient procurement at lower prices across different states. That could be done in the short term. In the long term, of course, small states could come together and create economies of scale to pool these new antimicrobials, which may have a higher price to begin with, but then with more guaranteed higher volume, they could negotiate lower price with suppliers. And this could be done with smaller states to begin with, but even we found that even in some cases, medium-sized states whose procurement quantities may be very low in certain high-end antimicrobials could pool together orders for these specialized drugs. So that was on the public sector side, but we also found that the private sector is quite heterogeneous and fragmented. And one may want to think about alternate mechanisms to pool demand from different private hospitals, especially smaller sized ones, again, whose individual procurement quantities may be very small, and as a result, they are usually charged a higher price. So utilizing mechanisms like the group purchase organizations, one could imagine aggregation of demand or orders from many small to medium-sized private hospitals, and in return, get access to these new generation antimicrobials at affordable prices. So these were the three main recommendations. We also had a bunch of other recommendations, which in the interest of time, I will not go through in detail. But this is only to highlight that you cannot unilaterally focus on access and hope to improve patient outcomes at a population level without paying attention to these other concomitant factors. For example, if you're going to go towards some kind of demand aggregation in small private hospitals, you want to be careful that this increased access doesn't come at the expense of increased resistance in the future. And so maybe one needs to think about updating accreditation standards that include some strong stewardship practices. And then these demand aggregation mechanisms could be made available to those hospitals which abide by these standards. And we've had some preliminary discussions with NABH on how their standards could be expanded to put more specific, more concrete language around antimicrobial stewardship practices. Think about this as some kind of a responsible pooled procurement, not available to everyone, but only if they can verify that they follow certain good practices. Similarly, use of antimicrobials at the high end must be supplemented with improved diagnostics. Only when we know that the bug is resistant to existing drugs should one go towards high-end antimicrobials. And currently, these systems are fairly weak in many small to medium-sized hospitals. I've talked about the PMJ scheme, but there's also discussion about introducing value-based care under those schemes, which means if a higher end antimicrobial is more expensive, but has better outcomes, and that can be shown through evidence, then perhaps those could be included under the benefits package. And as we increase access to these new generation antimicrobials, the surveillance mechanisms would have to be expanded so that these are also tracked over a period of time to check whether resistance is getting built up for these new generation antimicrobials as well. And then I've talked about updating the target antimicrobial profile for the country, which can inform innovation decisions by pharma companies in the long run. And while there is a national AMR action plan, which is very strong, very few states have adapted that national plan into their own plans. At the last count, I think there were 4 or 5 states. And even in those state action plans, there isn't very explicit and strong language around providing access to higher end antimicrobials. So that probably is an area where more concerted effort could be taken, which can then lead to efforts towards modifying the essential drug list, which will then eventually translate into better procurement practices. And that's it. Again, I'm happy to take questions now or during the panel discussions. Thank you so much.
Thank you so much, Professor Sarangdeo, for the insightful lecture. And it's very much good to hear from you and learn so many different aspects, because from the hospital side, we generally focus on certain healthcare specific angles. So, but you spoke it in a different way. I mean, all the three-legged or three-pronged approach, rather, access, innovation, and stewardship. So perhaps this is a right way how we should approach this. So thank you once again for this insightful talk. So I'll now move to the panel discussion. So before I move, let me introduce the eminent panelists. I do understand that they do not need an introduction, but as a formality, I have to introduce. So I'll be very short in my introduction. Otherwise, this will take a long time to introduce the eminent panelists. So I'll start with Dr. Arvind Taneja, sir. Sir is presently a senior consultant and chief advisor at Max Smart Hospital, Saket, New Delhi, in the division of pediatric medicine and infectious disease. Sir has been a stalwart in this field, and he has had long and distinguished career starting from Maulana Azad Medical College. He has an instrumental role in furthering the discipline of infectious disease in North India, including writing a book. So the next panelist, Dr. Anita Arora. So again, ma'am needs no introduction. So ma'am is presently the Director of Medical Operations, Group Head, Infection Prevention and Control, Fortis Healthcare India. She is also the Principal Assessor, NABH, and the past member of NABH Technical Committee, trainer for the Program of Implementation, POI, and SAFEI program. Dr. Arora was the SHIA ambassador in the year of 2010. She has done fellowship at the University of Virginia on global training program in occupational exposure prevention. And ma'am has also a green belt training to her credit in Six Sigma. So she has contributed in national guidelines on infection prevention control and a few IPC book chapters. And finally, Dr. Nitin Bansal, a very dynamic and energetic infectious disease physician, prominent in various forums. So he is, as I said, he is an infectious disease doctor having MD medicine and postdoctoral fellowship in infectious disease. So he's working as a consultant in infectious disease for AMSP project ICMR, New Delhi. And at the same time, he is also attached with Rajiv Gandhi Cancer Institute, New Delhi, for the infectious disease department. So he's having a lot of interest, keen interest in the field of immunocompromised host and infections with this population and hospital epidemiology and infection control. So thanks, everyone. And Professor Sarangdeo will be continuing with us. And so we'll start the panel discussion. And let me begin this with Dr. Arvind Taneja. Sir, we have discussed different angles of different aspects of this AMR mitigation. So as we see, it's not a, there is no single approach. There are multiple approaches, and you have been into this field for many years. So how do you see the role of collaboration, both internally and externally, to fight against AMR? Internally means within the healthcare system and outside the healthcare system to multiple agencies that can be private agency, public agency. And so if you can give us some overall idea, sir. Sir, you are on mute.
Am I audible now?
Yes, sir.
Okay, so thank you for the introduction. I would first say that the most important unfortunate use of antibiotics is in the tertiary care hospitals and sometimes also in the secondary care hospitals of our country. What we can do is what I will focus on, and one of those things is that we must establish a division of infectious disease in each secondary and tertiary care hospital, which is holding a infection control meeting frequently, like every month or so, which should be multidisciplinary. It should include nurses, people from the housekeeping staff, from the marketing department, to establish that we are a hospital which follows infection control practices and make it known to the people who get to know the hospital. The Infection Control Committee should be also helped by the Department of Microbiology, the Department of Surgery, the Department of Medicine, the Department of Pediatrics, where the antibiotics are most frequently used. And this committee should be helped also by an infection control nurse practitioner and a clinical pharmacist. Because if you review the antibiotic use by the clinical pharmacist, for example, they'll find a lot of places where antibiotics have been used disproportionately or empirically, and that will be pointed out to the committee, and the committee can make then a recommendation to the head of department of a particular surgical division or medical division, who will then disseminate the information to their various consultants to do a course correction kind of thing. So that is one way of flagging, and by one we flag improper antibiotic use in tertiary and secondary care hospitals.
Thank you, sir. So very well summarized. So as you understand, this is a teamed approach, and definitely you have to have a lot of inclusivity to be successful in this antimicrobial resistance problem. Thank you, sir. So my next question to Dr. Anita Arora, ma'am. Ma'am, as we understand, it's a one size fits all concept, right? So we have different maturity level in different parts of the country. We have resource limited nursing homes, we have district hospitals, we have teaching hospitals, and at the same time, we're also having tertiary and quaternary care premier hospitals in the country. So in the same way, we need to, segregate or, differentiate the strategies. So what would be the, teaching points from your side? How do you see this, and how do you, educate us how we should strategize to combat AMR basis the maturity level?
All right. Thank you so much. Thank you for the introduction, and good afternoon, everyone. So how to strategize AMR or combat AMR in a country like ours is a huge challenge. Right? That's the first thing we all know that because AMR or antimicrobial resistance is not just affected by human use, it's affected by non-human use. The environment, the veterinary, everything else affects our antibiotic resistance in a human being, whether they get colonized by it or subsequently infected by it. So that's the biggest challenge we have. But there are ways to address it. Of course, I will restrict myself to, of course, the human part, because we're here talking about that. Now, even in the human part, we have the community part and we have the hospital part, right? And in the hospitals, we have these various sizes, from a small clinic, 2-room clinic, to a proper nursing home, to even the government or the public hospitals, which are the district hospitals, the primary health centers, and other levels of the public hospitals, even large public hospitals. Most teaching hospitals are public hospitals, though there's a huge chunk of private teaching hospitals now. And of course, we have the private hospitals, so to speak, who are also of various sizes, and most of them, or quite a large number of them, are tertiary care. So that's the diversity and the entire spectrum which we have. Now, so basic principles remain the same. Right now, to prevent antimicrobial resistance, you can either not give an antibiotic, which is not a possibility, right? You've got to give an antibiotic, there will be infections, antimicrobial resistance. Any antibiotic started will develop resistance at one stage or at one point or the other, right? The only way we can do is to keep the pace slow or reduce the pace at which the antimicrobial resistance develops. And to reduce that pace, one is to, of course, do a whole lot of infection prevention and control measures. I won't talk about it. Basically, just that broad spectrum, which we need to do. But let me just talk about the antibiotic pieces. I think the first thing we need in our country is to have quality antimicrobials, okay, available. We have good companies who make them. Their patent gets over. Other companies start making them. The quality, I mean, that's one piece. That's one, okay, and the native antimicrobial. And then every beta-lactamase inhibitor is now combined with a beta-lactam to create all sorts of beta-lactamase inhibitor combinations. And of course, even EDTA and other stuff, right, which is there. Now that creates a huge challenge for all of us in the country when the manufacturer approaches a clinician with and is able to convince any clinician that that's the best antimicrobial ever made. So, and you can imagine the spectrum of this antimicrobial. So that's where that's the antimicrobial piece. So that's what we need to focus on. Then you did talk about that, health is a state subject. I think Professor Sarangdev dealt on it. So now, even if you create the AMR, the national and plan, to get to implement it is a big challenge. And I think the current strategy is working on the implementation piece, because in their earlier version, they never worked on the implementation piece. So we hope that that will help. So that's the part. And now when we have all this, I think the most important part remains is the diagnostic microbiology services to be available and clinicians to use them, right? If a clinician doesn't send a culture, what will grow? What will they know that is growing? And then putting up the antimicrobial sensitivity for it and getting a sense, knowing which antimicrobial will work, and then, of course, administering it. So that's the broad gist of what I just wanted to share. No, one last piece. And I think all concerned who prescribe an antimicrobial should undergo seriously a huge education and huge training, and not just one-time education. They need to be educated and re-educated. They need to unlearn certain stuff and learn certain stuff, and then progressively each time trained through in a scientific manner, evidence-based, whatever the CME hold, rather than, unfortunately through various providers of the various antimicrobials which are available, and which is not necessarily the complete correct information which they impart to the clinician. So that's it. Thank you so much.
Thank you, ma'am. Very well explained. And we do understand that we need to formulate and reformulate our strategies based on the maturity level and also the infrastructure, and it should be economic for us. Thank you so much once again. So my next question to Professor Sarangdev, sir, you are involved in the healthcare delivery and you're an expert into this. So, I mean, many times we often creep that India is a country where almost all antibiotics are available over the counter. So, I mean, too much of access maybe. So, I mean, from a healthcare personnel, so if you can explain what are the challenges of not having strict regulations or not being able to restrict this over-the-counter availability of many such antibiotics in our country. So this also includes human and also, animal husbandry.
Yeah, I mean, I'll be honest, I don't understand the animal husbandry side of things very well, so I will leave that out of the discussion.
Sure.
I guess for this audience, the issue is very apparent and real that antibiotics are freely available over the counter. But let me just maybe connect a few comments. Dr. Taneja mentioned, I think rightly so, that the big problem is coming from secondary and tertiary care hospitals, right? So one could argue, if that is the source of the problem, then if antibiotics are freely available over the counter, it shouldn't be that big a deal. But I think if you think through this carefully from a patient pathway perspective, a patient who is admitted in a secondary tertiary care hospital, right, is given a prescription that, oh, we need this antibiotic, it's not available here. Or, even if it's available here, the family member is going to say, okay, let me look, maybe I'll get a, cheaper price somewhere else. And so that person is going to go out and go to a quote unquote retail pharmacy. And then if that higher end drug is available, that starts to pose a problem, right? So that's one way by which these different seemingly contradictory things come together. Now, are there regulations currently? Sure. There is a Schedule H1 regulation, which says if you are prescribing drugs in a certain list, you should keep a log of them. Those will be checked, so on and so forth. But as many things in our country, the scale and the complexity of the problem means that the oversight on such regulations is hard. Okay. There are some studies done to show whether introduction of such regulations has had any impact on prescription practices. I think the evidence is not, I would say, not very rigorous and not very high quality, because underlying data is hard to come by. One concern that has been expressed, again, I don't know to what extent this is true, is if you tighten the noose quite a bit, right? If you say, I'm going to check on the Schedule H1 register very, very carefully, there is an unintended consequence possible, which is a lot of pharmacies will say, listen, I'm not going to even stock these drugs because it's a headache. I'm visited by drug inspectors, and even if I make a slight mistake here and there, they want to catch me. So I don't know to what extent this has played out, but it's one concern that has been expressed, that it may eventually lead to restricted access. I'll pause there. I mean, again, there are many aspects to this, but in the interest of time, I'll pause here.
Thank you, Professor Deo. I think very well said that yes, we can often complain that yes, too much of access, but at the same time, we should all understand that there are certain flip sides. So yes, so it's a gray area, and definitely we can come up with some balanced, approach in between. So my next question to Dr. Nitin Bansal. So it's rather specific to you, Dr. Bansal. So what is the role of diagnostic stewardship in combating antimicrobial resistance? As your infectious disease doctor, so how do you see the role of diagnostic stewardship?
Thank you, sir, for asking me to sit on this panel. It's an esteemed panel. I feel I am a little misfit into this panel, but I think that's how AMR is. We need to expand our thought processes and probably interact with a lot of stakeholders rather than restricting to a single specialty. So coming back to your question, I think from diagnostic stewardship point of view, first I would like to just clarify, to the audience also, that stewardship does not mean that we want to restrict something. I mean, generally the common myth is that stewardship means restricting antibiotics, or sometimes what I hear from my colleagues, non-ID colleagues, is that if you ask him to see the patient, it means he will make you feel guilty of writing an antibiotic. So that is not what stewardship means. Stewardship means rationalizing antibiotic usage, and that's where diagnostic stewardship comes very much into play. So it's very easy to say that don't write this antibiotic, it's a viral infection, or you don't need such high-end antibiotic. It's going to go away with the normal first generation, second generation cephalosporins, etc. But unless and until you have a foolproof diagnosis, it's very difficult to convince the doctor. And nowadays, in today's age, even to convince a patient also. I mean, the patient also demands a lot of. You have to fulfill the patient's demands as well sometimes. So diagnostic stewardship has a very, very important role in fighting AMR. And that's where I think Dr. Sarang's lecture was quite, interesting for me. He was discussing about accessibility to antibiotics, but I think we should also simultaneously study about the accessibility to diagnostic tests, which Madam also spoke about. And most of the diagnostic tests are either not available, or if they're available, they're very rarely used at many centers apart from tertiary care centers. And another problem which we face in tertiary care centers is over-utility of these tests. Like cultures will be sent for everything, even if the patient is not having particular problem, urine culture will be sent. So we need to find a balance between accessibility, usability, and probably, what should I say, equity, how equally we can distribute this very vital resource of diagnostics. And also we need to be very smart in developing diagnostics. I think you are from the diagnostic development kind of an industry, where we should tailor down it to our own needs. We can't just keep on, copy pasting is a very negative word, but we can't just keep on adapting that from the Western countries. We need to definitely tailor it down probably like tailor it down to the ground root level so that we can catch the actual bug, actual mechanism of resistance, and not the mechanism system which we do not need actually. So those things need to be taken into when we are speaking about diagnostic stewardship, and it has a huge role in fighting AMR.
Thank you, Dr. Bansal, for your inputs. And we do appreciate the role of ICMR here for enlisting the essential drugs and also the investigation. So this has actually helped the country in a big way. So your points are very well noted. So I'll come back to Dr. Arvind Taneja, sir, again. So, sir, we see there are certain gaps between the public and private setups as far as controlling antimicrobial resistance are concerned. So what do you think that what are the gaps and how we can breach the gaps as far as implementation is concerned?
See, in the public sector, a lot of antibiotics are not available. Public sector survives on basically maybe 2 or 3 antibiotics, but when they come to private sector, there is a huge gamut of antibiotics that are used. So I'll come back to the fact that we need more inputs from the microbiology departments into decisions about antibiotic usage. There are instances where a lot of doctors' input is needed. I'll give an example that patients come in with, let's say, a non-infectious disease problem. And as a matter of routine, the antibiotics are started, whether it is in the ICU or whether it is in the wards. So ultimately, it ends up in a lot of unnecessary antibiotic use. So every person who comes to the hospital does not need an antibiotic. I think that is a message that should go through by doctor education, basically. I know for a fact that in our ICU, at least where I work, any child who comes in with an infection immediately gets started on ceftriaxone, which is doesn't make sense whatsoever. Secondly, doctors have to be educated how to use the microbiology laboratory sensibly. A lot of doctors do not use it sensibly. I'll give an example that if a person with an infection walks in and you think that there may be a serious infection, one should draw a blood culture, which is often not done. And if you draw a blood culture, there's a technique to doing a venipuncture to draw a blood culture. The way that the site has to be cleaned, if necessary, gloves have to be worn before drawing the blood culture is something, again, by doctor education. Third thing where things many times go wrong, or for example, is from the microbiology laboratory itself. A positive blood culture shows up at 16 hours of incubation or so. The information doesn't come through to the treating doctor till 36 hours later when the official report is available on paper. If a blood culture is positive, it is the responsibility of the microbiology laboratory to contact the doctor and say, look, we have grown this particular bacteria in the bloodstream. You better take action or give the appropriate antibiotic to that person. Many times I will also say things like doctors don't use things like gram stain. A gram stain will give you a lot of indication if used independently. And if a gram stain is sent, the report will not come back till 36 hours later. You should get a gram stain report within 3 hours of sending it to the lab. They are not basically staffed enough to give this kind of a report within 3 hours of it being sent. Now, a lot of information that needs to be given to the doctor is not given at all. So this is something that I would talk at the tertiary care level. At the primary care level, where a lot of antibiotics are used, I would say at least we should prevent or educate the informal service provider. That means the person who's sitting in that small town or whatever, that the minute a person comes in with fever, he should not be given cefixime or something like that, which is the drug of first choice of the people sitting there. So educating the informal service provider will prevent a lot of antibiotic misuse in the community. Carrying on from there, I would also talk about inappropriate antibiotic combinations, like Dr. Anita Arora just said, that there are a lot of combinations in the market which should not be really there. The Drug Control Authority of India lets it pass through. I'll give you an example. A person who comes in with loose motions, the first drug that the informal service provider or even the secondary level or the tertiary level doctor will prescribe is a combination of either an aminoglycoside, or they will use something like ofloxacin and combine it with metronidazole. This is an irrational combination, basically. So these combinations should not be available in the market at all. And the drug control authority has to step in to at least cut off the problem at the source. So thank you. This is just a few of my thoughts. And one last thing. A lot of homeopaths and Ayurveds are using antibiotics as part of their armamentarium. I think at least this can be discouraged. So educating the informal service provider, preventing its use by homeopaths and Ayurveds, getting better coordination between the microbiology laboratory and its reporting system. And I'm sorry, but a lot of antibiotic misuse is done by the surgical departments. They do not think in terms of what the possible bacteria will complicate that particular surgery. Preventively, they get a lot of antibiotics, which are not really necessary. So I think, in short, that's my feeling. Thank you.
Excellent, sir. It's great to learn from you. Yes, as you rightly said, often we have the systems, but because of improper communication, we cannot take full benefit out of the existing infrastructure. So, and also education, which is really a great important factor in this journey. So thank you so much. So my next question to Dr. Anita Arora, ma'am, you are a microbiologist. At the same time, you have assumed very high administrative positions also. So you have seen the both parts of the spectrum. So we often see that many times hospitals try to adopt antimicrobial stewardship programs in the country, but they often do not get the blessing of the top management. And finally, they falter many of the times. I'm not generalizing this, but it's quite proven that, it's a top down as a blessing from management is kind of required. So, I mean, from your experience, ma'am, if you can share how we can best convince the so-called C-suite or the top management to invest in antimicrobial stewardship program, which is apparently not so attractive for them.
Right, thanks. So of course, the easiest would be and the best would be if your top management was someone who was convinced about it already and your matter is resolved, So I've worked in various locations and have had the luxury of having worked with someone who was already convinced, so my antimicrobial stewardship program was running very well. But you may also be facing because the antimicrobial stewardship program is not a revenue generating program per se. So obviously, and if somebody needs to implement an antimicrobial stewardship program, I'm also going to have to, as is perceived, which Dr. Nitin was mentioning, that, I'm curtailing the use of antibiotics. So that's why the top management may be initially hesitant about it. However, of course, it's the need of the hour. We need to do it. So we should go about, presenting it to the management as a both a cost-effective, even a revenue-generating system. And I'll share some examples on how we can do that. So you could start with the patient story. So if you had patient or patients who have had either high morbidity, had a long stay because of a infection, whether it was a bloodstream infection, whether it was a UTI or SSI usually, or surgical site infection usually happens after the patient is discharged. But one of these two, or even a ventilator-associated pneumonia, and you had a long stay patient, and there's been associated like great morbidity and unfortunate mortality too. And then, at the end, the patient's party has to pay the bill. That's where you can talk about how preventing infections would be a good idea. And so you could talk about the importance of an antimicrobial stewardship program on how to deal with it in that manner. So such examples would be one to do it. Now, of course, it's not going to be easy, and a good strategic, thought through, convincing business case would need to be presented to the top management. And while we have this, as far as, so you did, Professor Sarang talked about accreditation. Now, accreditation can only do so much. First of all, accreditation is voluntary, right? Though there are now so many reasons why you need to go in for at least the NABH accreditation, right? And the labs need to go in for NABL, but that's not relevant here. It's the NABH which is going to do the antimicrobial stewardship. But most people would just put some sketchy stuff in place, and that would defeat the whole purpose. So it would have to be the hospital staff, whoever takes on that role of, trying to be the person who's either going to take charge of the antimicrobial stewardship program. It could be an ID physician, an infectious disease physician, if you have one. It could be either a critical care person. It could be sometimes, the head of anesthesia. It could be anybody else with a serious interest in controlling infections or about having great, very passionate about antimicrobial use and its control. And I mention all these as clinicians because that's what our country is going to drive. It's not going to be clinical pharmacologists. They are few and far between. And the clinical pharmacists are even fewer or non-existent. And they are not empowered at all. The infection control officer, who's usually the microbiologist, will be told, listen, you stick to your lab. So that's why if these people together, which means the microbiologist or infection control officer, the clinical pharmacist or clinical pharmacologist, and a key physician could together develop a program, convincing program, which could be put up to the top management to, with details, how you're going to reduce the length of stay. And so that's going to translate into revenue because you're going to have a more rapid turnover of patients, more patients come in, that's one. When you reduce the length of stay without an infection, it also affects your own reputation because the patient party will go out and say, what measures you took to prevent infection and so on and so forth. So what you will need to, of course, the team needs to establish their credibility. The team also needs to really work hard towards doing it. Sometimes, if you're starting afresh, it may not work in one go. You may need to, it would be best if in the first go you're able to do it because you won't have another chance. You may not have another chance because if once you've lost the battle, that's it, so to speak. But there's no harm trying again and again till you're able to do it. Sometimes you may need to adopt another strategy. But whatever it is, as I said, you need a little comprehensive, crisp, meaningful business case that you put up to the management for them to get convinced that you're going to do it, that they're going to need it. And of course, if you can talk about how they're going to save money or even generate money, that language is what they actually understand. Okay? Thank you so much.
Excellent, madam. It's so well said and so well described. So yeah, essentially you have to speak in their language, so then we can have some chance of success. Thank you so much. This is really insightful, even for the juniors who are into this journey. So I'll come back to Professor Sarang Deo. So again, basis your expertise. So my question to you, what's your thought on the integration of systems which starts from the procurement, also interdepartmental alignments like pharmacy and other departments within the hospital, and finally also integrating human behavior. So I understand this is a very holistic question, but perhaps you're the right person to answer this.
Yeah, I'm glad you say that, because people typically tend to think of system as being different from human behavior. System is some kind of a mechanical interlinkage of.
Yes.
But we found very often that human behavior tends to drive system outcomes, right? It's not just a technocratic framework. So, before I go there, because see, the other element of system is economics, and I'm so glad that Dr. Arora brought this out. One of the things that I've heard often, and I'm very curious about, is how AMS is actually a good business case, right? Because there are various factors that go into it, but it's important because if you can demonstrate it, it can lead to a level of buy-in that may be difficult to do purely based on clinical health outcomes per se. So I'm very happy that that came out. On the human behavior bit, so I'll just say that we are currently undertaking a study that looks at possibility of using behavioral nudges, as they're called. There's a lot of behavioral economics theory on how we can change human behavior, not by providing explicit financial incentives. That's the standard economics approach, but just by changing some habits or by triggering certain things to which humans will respond. A good example is, for example, when we heard about different prescription practices, which all may not be very rational, right? So what if there was some kind of a machine learning algorithm where if the doctor started typing a certain drug name, then the sequence in which those drug names come would be based on underlying clinical evidence of what is rational, what is less rational, right? And so naturally, if the irrational combinations or drugs are 15th in the order, then the physician has to go through, whereas what is available on the top is something that is evidence-based. So that's just one example. There are many. I know people here will be familiar with such nudges used for hand washing. And they have varying levels of effectiveness. Some studies have shown that even after you remove the nudge, the behavior remains. In some other cases, the behavior goes back to normal. So it's not very straightforward. It would have to be contextualized. But yeah, I'll stop there just by saying that human behavior is an important element of systems, and so are incentives. And all of these are sort of linked together. So if a hospital wanted to come up with a package of change, they will have to keep all of these things in mind. Thank you.
Excellent, sir. So I think it's very well addressed. So it's an all-inclusive approach, perhaps, that will work best for this kind of tough situation. So I'll come back to Dr. Nitin Bansal. So as you're from ICMR, you're associated with ICMR. So we'd like to hear from you. As far as implementation of different things are concerned, especially, so what are the future strategies and key priorities in this fight against AMR in coming next 3 years?
So from as an ICMR consultant, I have been associated with the ICMR for an AMSP project. So that is something which is ongoing, which has been like for the last 1 year, it has been ongoing, and it's going to go for another 2 years at least. What we are planning to do, what we are doing in that project is that we have enrolled various tertiary care centers, and we have started implementing AMSP interventions in those centers. And we are studying the outcomes of we have got the baseline data. Now we are studying the effect of the AMSP interventions in terms of clinical outcomes. We are also not restricting ourselves to clinical outcomes. We have also included cost modeling into that. So that cost of the antibiotics is also being taken care, and also obviously the resistance pattern, which anyway is a part of routine microbiological outcome of any AMSP project. So we are going to study that AMSP interventions in terms of clinical outcome, economy outcome, microbiological outcomes, and the consumption of antibiotics also. So this is something which we are trying to do, and we hope that we are going to show some sort of a trend in which AMSP interventions had led to at least not deteriorating clinical outcomes and improving the resistance profile, and obviously some cost savings also, which will have a huge implication in terms of policy making for the future. So as of now, there's a lot of literature on AMSP interventions in Western countries, But in Indian countries, whatever literature is there on AMSP interventions is restricted to a single center or maybe 1 or 2 centers. So that's why the adoption of an AMSP program from a clinician point of view is very difficult, because they think they do not have any solid data coming from India or India-like countries where the AMSP intervention has shown some clinical benefits, economical benefits, and probably benefits in terms of antimicrobial resistance. So this is a big project for ICMR, which is already going on. Other projects which is about to get launched. This is genomic surveillance project, in which we are going to take study the various genomics involved in the resistance AMR. And again, it's going to be at a national level, so it's a big project. We also still have a genomic surveillance data coming from various centers, but data is restricted to very few isolates. So in the annual report which comes in from the ICMR almost for last 7-8 years, there is some genomic data which is coming, but that's only restricted to few isolates. So we're going to expand that genomic surveillance data so that we can get more insights on what resistance mechanisms are far more common in India, which will also help the future antibiotic formulations, like help the pharmaceutical industry who are going to make newer antibiotics pertaining to Indian problems. Another project which we are trying to launch is the capacity building, which already done. We have done part of it in terms of secondary care centers, capacity building for AMSP, capacity building for IPC, because this is what we actually observed, that there's lack of infection prevention control practices at various centers, primary care centers and secondary care centers. So we need to do capacity building for IPC also. So that is also being planned. Another is that we also are planning to come with treatment pathways for various syndromes. Like we recently published a guideline on carbapenem management of carbapenem resistant organisms. It's going to expand that treatment pathway thing into other organisms of trouble or importance in India, like resistant salmonella, or go into syndromic diagnosis like pneumonia and all these things. So this is what the the future plans of ICMR is.
Thank you so much. I think we really appreciate the role of ICMR in strategizing the policies and having undertaken these top priorities and also this surveillance activities. So thank you so much, Dr. Nitin Bansal, for your comprehensive explanation. So I'll come back to Dr. Arvind Taneja, sir. A little sensitive question to you, which is rather untouched in our country. So in other countries, we often see that patient advocacy group, they also play some role. They are playing some role for this antimicrobial resistance, so which is perhaps not so much active in our country. So do you think it's the time to include patient advocacy group in this battle? Sir, you're on mute.
Okay, thank you for the question. I think advocacy has to start with education, and the people who are getting the treatment need to be more aware that what is the role of higher antibiotics or antibiotics as a whole. I know that people believe that antibiotics are antipyretics. People believe that the minute they get a cold or a cough, they'll pop a tablet of azithromycin, thinking that this is going to help them get better faster. Unfortunately, the doctors also prescribe these antibiotics right, left, and center. A visit to a doctor is supposed to be not complete unless an antibiotic is a part of the prescription. So I think we need to educate the public, both by terms of media, both by terms of visual, auditory media, or journalists who write in newspapers, that taking an antibiotic is sometimes or often harmful. So if the pressure comes from the patient, that they have to be educated to question the doctor. Doctor, why are you prescribing me an antibiotic? I think if that one single question is asked from the medical professional, the medical professional will step back at least 2 steps from handing out antibiotics. Now, the same thing applies to the service providers who are dispensing medicines. They are making, part of their profit is coming from dispensing medicines. So, for advocacy, I think that has to be curbed, basically. So I think education of the patient in terms of mass media, to say that, and of course reinforced by the government, the ICMR or whatever. I think these are the steps I would start with, basically, to advocate not using inappropriate antibiotics. Thank you.
Thank you, sir. This is really good to know from you. Yes, Dr. Nitin, would you like to add anything?
I just want to add a quick comment here. We did a small study in our own center, Rajiv Gandhi Cancer Institute. We compared the consumption of azithromycin in 2019 to 2023 only on the prescriptions, only on the dispensations which are done for healthcare workers. So, I mean, in our hospital, you do not need a prescription to get azithromycin. It can be, if you're a healthcare worker, you can get it directly. The pharmacy can dispense you. So we have found that during the flu season, that is typically July, August, and September in Delhi, we found that the dispensation of azithromycin has come down for healthcare workers from 2019 to 2023. And I pertinently want to emphasize that it's because of the education. Now, most of the healthcare workers in our hospitals are educated enough that for the flu, they do not need to take azithromycin or any other antibiotic. They can get better on their own. But it has started to come down. It's not completely zero as of now.
Can I just make a small point on Dr. Bansal's this thing, that during the COVID epidemic, the azithromycin was prescribed like water. And so maybe the data is skewed if you control between between 2019 and 2023. Is it a real fall? I think the data is skewed because of the huge increase of azithromycin during the COVID epidemic. We were sometimes supported by the government and the states. I know that for a fact, many governments were handing out COVID kits from the state government, in which azithromycin was along with ivermectin, along with 2 or 3. Now, this was totally inappropriate. And here it was the government which was at fault, or the advisors to the government that was at fault. So,
Thank you, sir. Yeah. Thanks for sharing your feedback. So we have just last 2 questions, and I'll also take up few questions from the audience. So quickly, Dr. Anita Arora ma'am. So what kind of support you seek from policymakers? I mean to say government policymakers.
Okay, thank you. Government policymakers. Okay. All right. So maybe first of all, we should see whatever we have brought out as a regulation, Schedule H, etc. If we could actually implement it, right? Start by implementing what is already there in the public domain as a regulation. That's one. And 2, if in some way the National Action Plan could be, mandated to be state-wise. Like currently, we only have a couple of states who, through their own drive, somebody has taken it up, and probably somebody in the state health department, in the relevant department, was, got convinced by whoever approached them and started working on it, or was self-motivated and started working on it, But I think Kerala, MP, and probably 1 or 2 more states have, really implemented it in a true way. And I mean, I know how it happened in Kerala. So, I mean, does it need an individual to go approaching the government to tell them that, that you need to now work on it? No. So if I understand health is a state subject, but like we have certain central acts, like, the biomedical waste is now a central act implemented across the country. So why can't we do it for this? I understand it's going to be a challenge. And if nobody wants to, probably do but we've got to make a start. We've got to say, I'm going to take one state in the east one, the west one, the north one, and the south. Maybe start like that. Start slow and build on it. And I'm sure when they see that, you're not having suddenly an increase in mortality, or, patients are not dying. In fact, patients are getting better with lesser usage of antibiotics, or better, in a usage of antibiotics, then maybe we could do that. So that's from the government policy makers is what I would really like to see. Thank you.
Thank you, ma'am. Thank you. It's really good to know. And yes, I see great questions in the chat box. So I believe I could include all the questions in the panel discussion. So one great question that alternate therapies for antibiotics, possibly, it's phage therapy, which is being indicated to, which is really promising, but we do not have sufficient time. So we'll close the session with the last question to Professor Sarang Deo. So we discussed on the access part, stewardship part, but only one part which is left, innovation. So if you can just close the session with a two-liner on this innovation part. So as far as antimicrobials, diagnostics, so we'd like to hear from you, sir.
Thank you. Yeah, I do very little work in this area, so my comments may be limited. Two themes that we identified and which are important from a policy perspective. One, I'll emphasize again the target product profile, because the more we talk to experts who are drug development experts and also microbiologists, their point was that the resistance mechanisms in India are very different. So the drugs that are getting developed for Western markets, they may not automatically be useful in India. So that's a negative statement. I think the positive statement is, here are the mechanisms. So give targets to drug developers that they can work towards. And second is, make it easier for drug developers to enter Indian market for their clinical trials earlier, rather than having developed a product somewhere else and then try to again run some trials in the country to get approval. So I think those are the two things. It's a vast topic in itself. I'll stop there.
Excellent. I think it's a great insight from you. So I think we learned a lot from this panel discussion from the eminent panelists. We discussed about collaboration, we discussed about diagnostic stewardship and the pre-test probability, not unnecessary testing, need for communication, and also education. And also we talked about this implementation of different policies. So thank you so much to every panelist for sharing their views and years of experience in just 1 hour time. I understand many of the questions are little vague, but this is a great opportunity to learn from you, from your experience. So thank you so much once again. So I'll hand it over to Anwesha.
Thank you, Dr. Gupta. It has been such a tremendous and enriching learning experience for me. I've learned myself so much about AMR, and I realized how naive I am in this subject. So thank you for this wonderful, wonderful panel. I have to give a formal vote of thanks, and I wish this entire discussion should have continued for another hour or so, but we have to be cognizant of the time. So we'll have to wrap this up. So, my sincere thanks to all the participants who have taken out time and have joined this session. And thank you for your questions. And in case we have not been able to answer your questions, I'll send these questions to all the panelists, and I'll ensure from my side that your questions are answered from these panelists. There was some technical glitch in the beginning, but I'm so thankful to the Avian team who has been at the back end to support us. So many thanks to the Avian team who is with us. Thank you all the panelists, to Dr. Devkishore Gupta, Professor Sarang Deo, Dr. Arvind Taneja, Dr. Nitin Bansal, and Dr. Anita Arora, and everyone who has joined this panel. I would also like to thank, my secretariat team, secretariat team here in NATHEALTH, who's been very supportive in getting all the things in the back end. So really thankful to all of you. We'll have this recording available on our social media sites. And, very soon we will share the link to all of you. And stay tuned for our NATHEALTH Expert Speak Series, because the next one is due on 17th of November, and that is on data security and privacy. So thank you, everyone. Have a wonderful evening, and thank you for joining the panel.